Hello and welcome to week 5 of Trauma and Recovery. This week we are going to be looking at treatment approaches, applications, and objectives. And I really hope that you are excited as we begin to look at the formal treatment process for treating trauma-related disorders, or even those that do not have a diagnosable condition but have been impacted by trauma in some way. So, we set the stage for that last week as we looked at the aspect of screening and assessment. So, if you're not feeling strong on those materials, be sure you get a firm grasp of that aspect before we begin to look at trauma informed treatment specifically, as that will be important to progress uh, in that way, because it does require formal assessment and then treatment. Okay, so then first a little background. Um, when we look at treatment, or before even formal treatment, one of the things that we really want to concentrate on is this aspect of stabilization. So, when we're trying to determine whether it's going to be treatment or whether we're going to be focusing on stabilization, but maybe not necessarily treatment or certain levels of treatment, the main determinant will be the setting. So we first examine, are there clinical services in the setting? And if so, to what extent? In any setting where there are individuals with whom we work that have a trauma background, working towards a sense of safety and stabilization is vital. And we've already established earlier in this class that for most of us and in most of our settings, that's most of our clients, most of our guests, so on. So we want to ensure that they have services that will help them to begin to regain what was lost in the trauma. And that's where that first phase, that aspect of safety and stabilization, comes in. So, for those providing clinical services, we still need to determine to what extent they have services. So let's start with those that maybe in a setting that do not have any clinical services available. So this might be a residential setting where they have a lot that goes towards safety and stabilization, just in the sense of having a safe place to stay, maybe starting to establish some routine and some services, perhaps accessing some things through referral and so on. They begin to build that aspect. But how we approach the person also is important in ensuring that we don't have things that are too overbearing, for example, that may come across as a sense of power and control that they might have had in their, like if they were sexually abused, for example. That's going to be a situation where they felt very powerless, where their power was taken from them by force. So coming across as very authoritarian is going to mirror that and be more harmful than beneficial for the individual. So those are the sorts of things that we want to be aware of in the first part of treatment, or the first early days of working with a client with a trauma background. So in many settings, there will be at least some case management. So that would be a level of clinical services. And really, case management is all about the aspect of stabilization. So there's a lot of work done in that aspect when we are taking care of case management needs of the individuals. Then there may be some facilities that have addiction counseling, for example, but maybe not treatment for other mental health conditions. So, in those settings, what might happen is the person may receive formal counseling for their addiction at the facility. There would likely be some case management as part of that as well. And then, if there is another diagnosable condition, so for example, a trauma related disorder, then the treatment for that may be done by referral. Then one additional consideration is that even at a facility where there are mental health counselors, maybe a licensed professional counselor, or even a psychologist or other doctoral level position, if the individual does not have specific treatment, or excuse me, training and experience in treating dissociative disorders, then that may be done by referral. So they may work with them regarding maybe PTSD. However, if they have a dissociative identity disorder and the clinician does not have specific training and experience with that, then they may refer for specific specialized treatment for that particular disorder. So it's all about this aspect of boundaries of competence, which is essentially ensuring that the treatment that you provide is aligned with the level of experience and training and so on of the individual. So, now some specific information about treatment. We have already spoken a little bit about this aspect of the three-phase treatment process, and that is what the Gingrich text covers. And it really is widely used and accepted. It's kind of considered the gold standard in the field. There are, however, other evidence based treatment approaches, and one option that we will look at is in the supplemental reading this week on this component based psychotherapy. Now, you first looked at this article in week 3. This week, you're going to read the second half of the article, and that focuses on this particular treatment approach. So you will also do a paper that compares treatment approaches, specifically these two, and you will see that they both start out focusing on the aspect of safety and stabilization. Now, I've said that several times already in this recording, and we will continue to revisit those components, and that is on purpose. That is the primary thing that needs to be in the forefront of everyone's mind who is working with individuals who have experienced trauma. So, both of these approaches do consider those. The component based psychotherapy has 4 components, as they're called, as the name suggests. And the first two really mirror the aspects of safety and stabilization. And so they still do address those needs. The first component varies a little bit in that it specifically looks at the relationship, and that's an important way of addressing the aspect of safety and stabilization. They just put a specific aspect of that relationship piece. So take a look at that in your assignment and consider those aspects in your comparison and contrast. Now, one thing I want to bring up is that the process is not linear. So what do I mean by that? When we think of a three-phase treatment process, one of the things that would potentially come to mind is you might picture a client going from phase one and then neatly to phase two and then phase three, and then they're done. And in many areas of the treatment field, including many aspects of addiction counseling, that's just not a realistic picture. And it's not even really the design in the three-phase treatment process. So, for example, in phase two, the individual will start revisiting and working on addressing some of the memories of their trauma. That process can be really just grueling. It can be very difficult. And when they are working through processing those memories, they may have significant mental health symptoms, and there may be situations during that process, perhaps several times during that process, where it's important to go back and reestablish a sense of safety, and in some cases, maybe even reestablish some stabilization. So that is an expected part of the process. It's not even considered a regression. It's just expected and accepted that the person will need to, on an ongoing basis, continually go back to that place of experiencing and establishing and feeling that sense of safety. So it's not a neat linear progression, phase one, and then you're done and you never go back to phase one aspects and so on. So, the main focus that we take in this class is really honing in on that phase one aspect, the safety and stabilization, for a couple of reasons. One, that's the important starting place, and as we just discussed, that's also an area that we continue to come back to. And then also because in many facilities, that will be where the treatment starts, and then any treatment on phase two and phase three would be done perhaps by referral. So we're going to really focus on aspects that will help and reinforce the aspects of establishing safety and stabilization. Next week, there will be some specific tools and strategies towards those parts. And we're going to begin preparing for that, both in this week's material and also in this week's live session. So we do hope to see you in the live session. We always prefer to connect with you live, and for anyone who at all can, we hope to see you in the live session on Tuesday night. If that's not possible, of course, there is the second option. Keep in mind, there is a one-letter grade deduction if you don't have one of the excused reasons for having to do the second option. In the session, we're going to provide an opportunity to reflect on what your role will be in trauma-informed care, and it'll be based on the materials, but also based on either your setting that you work in now or your desired setting if you're not currently working in the field. And then we're going to have a question and answer time for how to achieve a trauma-informed approach in that setting. So that discussion will hopefully prepare you for the upcoming assignment next week. You might want to take a peek at that assignment before coming to the live session so that if it raises any questions in your mind, you can be prepared to ask those in the live session. So that's where we will pick up. And so we'll talk more about this in that live session on Tuesday night of this week. So, hope to see you all there. And that's a wrap for this overview of week 5.